Hi Roger, thanks very much for joining us and for wanting to be a part of Scott Gem Stories and appear in one of our videos. It's great to have you. I was wondering if you could start us off by introducing yourself and telling us a bit about your current and past roles.
My name is Roger Strasser. My background is as a rural general practitioner in Australia. In fact, I was in practice in rural Australia, a place called Moe, about 2 hours east of Melbourne, for almost 20 years. During that time, I became involved very much in academic medicine, and I was appointed in 1992 as the first professor of rural health in Australia, and I was the head of the Monash University School of Rural Health. Monash University is the biggest university in Australia, and the medical school is in Melbourne. But I wasn't in Melbourne. I was in the rural area where I practiced, and the School of Rural Health was like a rural branch of the Metropolitan Medical School. By the time I left in 2002, the school had 4 main sites and a network of other teaching and research sites spread over quite a large rural area. And then in 2002, the opportunity came for me to move to Canada and to be involved in establishing a brand new medical school, the Northern Ontario School of Medicine, or NOSM. And this was an opportunity to be involved in establishing a full medical school that was multi-site and rural-based. And so I moved to Canada with my wife, Professor Sarah Strasser. She's also a rural GP background and academic medicine. And we have 5 children. So the 5 children and Sarah and I all moved to Canada. And we joined others in establishing Northern Ontario School of Medicine, or NOSM. And I was there, the founding dean and the chief executive officer of NOSM from 2002 until 2019. So this is 2020, and now I'm speaking to you from New Zealand because earlier this year I took up the position of Professor of Rural Health at the University of Waikato in Hamilton, New Zealand, in the North Island of New Zealand. So that's where I am today. This truly is a transcontinental interview that we're conducting. Northern Ontario is a vast geographic area in Canada. It's something over 800,000 square kilometres, less than 800,000 population. And essentially, if you can picture Canada in your mind, it's north of the Great Lakes and south of Hudson Bay and James Bay. There are 5 larger population centres, that's population of over 50,000, and then all of the rest are 10,000 or less. So lots of small, rural, remote communities, large distances. There are also 2 populations of special interest in addition to rural and remote people living in rural and remote communities, also people who were the original Canadians, Indigenous Canadians, First Nations and Métis peoples, and Francophones, that's people for whom French is their home language. So Northern Ontario had really always had a shortage of healthcare providers, and the health status of the people was worse than the general population in Ontario and in Canada as a whole. And so 2000 and 2001, the people and the communities across Northern Ontario really advocated, they came together, there was a widespread community movement that said if we're ever going to have enough doctors and other health professionals in Northern Ontario, if we're ever going to improve the health of the people of Northern Ontario, we really need our own Northern Ontario School of Medicine. And in 2001, the Ontario government accepted that proposition. And so it was in that context in 2002 that I was recruited and went with Sarah and the 5 children to Canada to join others to establish Northern Ontario School of Medicine. And when I say join others, I think it's really important to understand that the school came into existence because of that widespread community movement. And that really provided the basis for the school to be established with an explicit social accountability mandate. So that's a commitment to be responsive to the health needs of the people and the communities of Northern Ontario, with a focus on improving the health of the people of Northern Ontario. And that social accountability mandate is actually written into the founding documents that established the school. So that certainly makes the school different. It's the first medical school in Canada established with a social accountability mandate. And really the school was developed with active participation of people and communities right across Northern Ontario, what we call community engagement. What we did, really the very first public event of the school was a curriculum workshop. We actually invited everybody in Northern Ontario who had an interest to come together. And we were there for 3 days in January of 2003. And essentially, this group helped to develop the Made in Northern Ontario aspects of the school. And we asked the people who were coming to this workshop to describe the characteristics of the doctors that they thought are needed in Northern Ontario. And very interesting range of replies. Many of the responses were similar to other community consultations that had happened in Ontario and other parts of the world about what people look for in terms of doctors. But there were 3 characteristics that stood out. The first was certainly special to Northern Ontario. That was doctors with a passion for living and working in Northern Ontario. The second was doctors who are members of the health team. So collaborative, part of the interprofessional team care providers. And third, doctors who are responsive to the social, cultural, geographic, linguistic diversity of Northern Ontario. And one of the key aspects of the school that's important to understand is that we developed the school in the Northern Ontario context for the Northern Ontario context. The way that I like to help people to understand this is to talk about the traveller in the countryside in Ireland who wants to get to Dublin. Like, he wants to get to Dublin and he doesn't know how to get there from where he is. And he sees a farmer in the field and he goes up to the farmer and he says, "How do I get to Dublin from here?" The farmer stops for a minute, looks into the distance, and then turns to the traveller and says, "If you want to get to Dublin, I wouldn't start from here." The point of the story is that we didn't take an off-the-shelf model of a medical school and somehow try and modify it and make it fit in Northern Ontario. We started in Northern Ontario, in the Northern Ontario context, and we certainly drew on research evidence and experience in other medical schools across Canada and around the world. So every aspect of the Northern Ontario program and the school was tried and proven somewhere else. But the package, the total package, which is Northern Ontario School of Medicine, happens only in Northern Ontario. I think that's something that really makes Northern Ontario School of Medicine stand out as being different from the other medical schools in Canada.
One of the interesting features of the curriculum which caught my eye was that it features teaching relating to the native peoples of Canada. So could you tell us a bit more about that?
That workshop in Sault Ste. Marie, the curriculum workshop, listening to the discussions, I realized that if we were really going to understand and address the expectations of the Indigenous peoples of Northern Ontario, we needed to have a separate workshop, just Indigenous peoples. And so we did that. That was called Follow Your Dreams, that workshop, or community partnership gathering. And we've held one every 2 or 3 years ever since. So reporting back to the Indigenous people and seeking further guidance from them. But the recommendations from the Follow Your Dreams report really provided the framework for developing the Indigenous dimensions of the school. It included establishing an Indigenous Affairs unit, so Director of Indigenous Affairs, and working within the school. It included actually having all of the medical students experiencing the life and Indigenous communities early on in their education. So our medical students, in the end of first year, they have 4 weeks living and learning in Indigenous communities. This is an immersive cultural experience. They're there to learn from the community about the history, the tradition, the culture, the social and the health issues. And this includes, usually it's 2 students per community. This includes the most remote communities, fly-in, fly-out communities that really you can only access by airplane, or in the winter they cut ice roads to bring in heavy supplies. So there's an intense focus really on our students learning from and understanding the Indigenous worldview and their experience of health and health issues to be able to be responsive to their health needs. What we developed what we call distributed community engaged learning as our distinctive model of medical education and health research. Distributed means actually over 90 sites across Northern Ontario, where our students and our trainees and other health learners may undertake part of their clinical learning. So that 90 includes something usually about 36 Indigenous communities in first year. In second year, the students leave the university cities of Thunder Bay and Sudbury twice for 4-week integrated community experiences. And these are, whereas first year it's a community experience with the Indigenous communities, in second year it's a clinical experience, and the students are attached to the doctors and the health team in small communities, usually less than 5,000 population. And so they're learning about the challenges and the opportunities of providing care in small rural communities. I should say that while they're in these communities, but in first and second year, they're still doing their academic studies. So the main means of curriculum delivery is small group learning, what we call patient-centered case-based learning. The cases are complex real-life scenarios set in real Northern Ontario communities. And so even in the classroom, the students are learning and preparing to practice in the Northern Ontario context. I should also mention that the students right from week 1 of year 1, they're learning their clinical skills. So we have a half day each week in the clinical skills labs. Community members, part of the community engagement, I guess, community members volunteer and they're trained to standardise patients. So the students are learning history taking and physical examination and so on right from the beginning, and the cases are woven into the theme. So there's usually a 6-week-long module that each module has the cases are to bring out particular clinical problems that are in a system like the cardiorespiratory system or the renal system and so on. So that's how the curriculum is organised in particularly the first 2 years. There's also a half day each week where the students go into a whole range of community settings when they're not out of Thunder Bay and Sudbury, in Thunder Bay and Sudbury. This is a community interprofessional learning. The students are in the settings, about a third doctors are main service providers, about a third of the settings other members of the health team are the main service providers, and a third are more community or welfare services. So that's also woven into the first 2 years of the program. And then in third year, just like Scott Gem, the students actually leave Thunder Bay, they leave Sudbury, and they go to one of 15 other communities in Northern Ontario, and they live in that community for the whole academic year, and they're based in general practice and they see patients. So similar to the longitudinal integrated clerkship that you have with Scott Gem, and of course for Scotland was pioneered by Dundee with the Dundee LIC. That model, the LIC, has been around for decades as a small parallel stream. A small number of students do that and in the United States, in Australia and other places. But actually, Northern Ontario School of Medicine was the first school in the world where all of the students undertake a longitudinal integrated clerkship. Because of the active participation of the communities, we call this the comprehensive community clerkship. And I should mention with the distributed community engaged learning, I've mentioned over 90 sites. Now, obviously, in order for that to be workable, we need electronic communications connecting the sites both in real time and asynchronously. And we have an extensive digital library service. That means if you have the internet, you have access to educational resources and information, pretty much the same as if you were in the big city, like in a teaching hospital. But the centerpiece of distributed community engaged learning is community engagement, the interdependent partnership that the school has with the communities of Northern Ontario. And so the communities are very much involved in the development and delivery of the education program, in hosting the students and helping the students and their families to feel at home in the community. And obviously there's a potential future recruitment opportunity for those communities, as well as all kinds of other aspects of community capacity building, involvement in research and other education activities and so on. So community engagement really is a central feature of our curriculum. And overall, I'm now describing this as immersive community engaged education. My observation, going back over many years now, is that rural practitioners are extended generalists. So if you look at the work of rural practitioners compared to their counterparts in the city, they provide a wide range of services. They carry a high level of clinical responsibility in relative professional isolation. And that's true for doctors, so general practitioners and other specialists like surgeons, pediatricians, and so on in rural practice. It's also true for other healthcare providers like nurses and pharmacists and physiotherapists. So rural practitioners are extended generalists. And I would say that for NOSM, understanding that and ensuring that the students have the opportunity to really experience for themselves the excitement and the rewards of practicing as rural generalists is very important. Medical students the world over are ambitious high achievers. They want to be the best kind of doctor they can. So if the senior clinical teachers, the role models that they have are teaching hospital subspecialists, they want to be teaching hospital subspecialists. In Northern Ontario, our students, particularly with the comprehensive community clerkship, our students, the principal clinical teachers and role models are rural generalists. And I think that's one of the key contributors to the fact that so many of our graduates have chosen careers as generalists and in general practice and other specialties. I think also the intensity of the interactions with patients actually motivates you to study hard and to learn to do the best you can for your patients. So within I don't know how long it took you, but usually it's within a couple of months, the students have really become part of the health team and they think and talk about going to work rather than going to study. And so they're developing that social accountability orientation, the focus on addressing the health needs of the people and the communities that they have the privilege to serve. And so I think that's an important contribution. Probably the message from the students that best sums up their perspective on the NOSM curriculum and generalism is the statement, you don't know it until you live it. You don't know it until you live it. And so it's that immersive, community-engaged learning that our students have in the communities, guided by the patients and with the rural generalist role models, I think are really key contributors to our students graduating with an understanding and an inclination, a desire to become generalists in whichever specialty they choose to follow.
And that kind of brings you on to the next question, which was what kind of things have graduates of Northern Ontario School of Medicine gone on to do as a career?
Driving force behind the school being established was the desire that there would be a better supply, a reliable supply of doctors and other members of the health workforce in Northern Ontario. And that is what seems to be happening. So 62% of the graduates of Northern Ontario School of Medicine are training in general practice, mostly for rural general practice. Now 62% is almost double the national average for Canada. 33% of the NOSM graduates are training in other general specialties like general medicine, general surgery, pediatrics, which leaves 5% training in subspecialties like neurology, radiation, oncology, dermatology. And that 5% is important to us for two reasons. The first is that we need those subspecialists in Northern Ontario. They have to go elsewhere for their training, but they are actually coming back. And the other is that it shows that even though we have a very different curriculum model and learning environment in Northern Ontario from the other medical schools, the school actually produces high quality graduates, doctors who are very competitive when it comes to matching to those very competitive subspecialty training programs. So generally speaking, in fact, what happens in Canada is there's a national match to residency training, as it's called. Vocational training is called residency training in Canada. And most years, all of the NOSM graduates are matched to a residency program in the first round of the national match. And that hasn't happened for another medical school. That's a whole class being matched in the first round for, I think, 20, 25 years. So that's something that helps NOSM, I guess, to stand out compared to the other medical schools in Canada as well. So that's where they go after they graduate in medicine. In Canada, the medical schools actually also organise postgraduate training or vocational training. And so NOSM has residency training programs in general practice and 8 other general specialties. And what we found is, particularly those who did their undergraduate and then their postgraduate in Northern Ontario, 94% of those doctors are practicing in Northern Ontario. And that includes actually the small communities. And, I mean, there's still a lot of small communities in Northern Ontario that are really struggling because of all of the other factors that come into play in the recruitment and retention. But the overall picture is one that's a dramatic improvement compared to before NOSM. For example, we did a study a few years ago now where we looked at 8 communities, small communities, that before NOSM really were struggling. Like they had between them 30 full-time equivalent vacancies. At the time of the study, they had 1 vacancy. They'd gone from crisis mode, filling gaps next week and next month, to planning ahead, and they were spending less money actually on recruitment. So they're definitely, for that group of communities that really embraced the NOSM model and worked with the school, that had paid dividends for them. It's probably worth mentioning something else when we talk about money, which is actually looking at the economic impact of the school. So, you know, conventional medical education, you've got lots of students crowded into big lecture theatres and teaching hospitals in the city. Pretty much by definition, the per student per year cost would be less than any sort of distributed model of education as we have in Northern Ontario. And so we were fortunate that the Ontario government had commissioned a business plan that factored in the additional costs of travel, communications, the cultural and social dimensions and so on, so that we started with a larger per student per year budget. But we needed to demonstrate that actually this was a worthwhile investment for the Ontario government. And so we twice done studies looking at the economic impact, and we've shown actually a more than 2-for-1 multiplier effect. That is, as an example, in 2016-17, the budget for the school, that's Ontario taxpayer money, was about $43 million. The level of new economic activity in Northern Ontario communities, that's economic activity that would not be there without the medical school, was over $120 million. And that economic benefit actually flowing through to the small communities. So it's not just the large communities, but the small communities actually more or less, the numbers are more or less proportional to how many students and residents, other learners that they actually host in that community. So we demonstrated that this is a really worthwhile return on investment, real value for money for the Ontario taxpayers, and that's been important. I think something else that's been important is the social impact of the school, and we studied that and we found that there was a kind of a sense of collective community empowerment, summed up by the phrase, if we can do a successful medical school, we can do anything.
Thank you very much indeed for speaking to us today and answering all these questions for me. And yeah, I think there's been no technical hitches and everything seems to have worked fine intercontinentally. So from Campbelltown in Argyll in southwest Scotland across to New Zealand, yeah, thank you very much for your time, Roger.